Chapter 20, Vascular Anatomy, Screencast 1. This first screencast will focus primarily on arteries, and what I want to address first is just an overview of the vessels that we have introduced before. And the other thing that I'm going to try to emphasize in this screencast is the anatomical structures that we find in arteries and veins and how they carry over to how these vessels perform their overall function. When we talk about arteries, we're talking about vessels that are taking blood from the heart and to capillary beds. Veins will be transporting blood from capillaries back to the heart. So this is a little different than what we saw previously. They were just general generic definitions with arteries, any vessel that leaves the heart, and veins, any vessel that comes back to the heart. Here, we're actually throwing in a capillary bed, which makes sense because that's kind of connecting the two together. Capillaries are going to be microscopic vessels, and this is where exchange is actually taking place between blood and tissue. Now, a couple of things that I want to point out here as we look at this diagram, and I want to point out some similarities that we are going to find between arteries and veins. All two of these vessels, arteries and veins, have the same three tunics. They have an innermost layer, which is the tunica intima. There is a middle layer, which is tunica media, which is vascular smooth muscle. And there is an outer layer, which is the tunica externa, and that's just connective tissue. So keep in mind, both of these vessels have the same basic underlying architecture, but there are going to be some differences. Probably one of the biggest differences between arteries and veins will be how more well developed the media is, the tunica media. And that's going to be a much more well-developed layer of vascular smooth muscle. Keep in mind, veins also have vascular smooth muscle, but it's just not as well developed as what we typically see in arteries. Now, that also carries over to something else I want to address. When we talk about arteries, we want to think of them as a pressure reservoir, whereas veins are going to be a volume reservoir. So when we look at an artery, it is able to withstand much higher pressures, whereas veins can actually hold a relatively large volume of blood without an increase in pressure. So one of the things that you'll hear me say, on the arterial side, pressure is our friend, but on the venous side, pressure is our enemy. And we'll talk about this a little bit later when we move into vascular physiology. But the thing I want to keep in mind here is that these vessels are anatomically constructed to serve their underlying function, and that's going to be really important. Now, as I indicated, when we talk about the layers, there's three of them. The innermost layer is the tunica intima, and that is going to be the innermost layer of a vessel. And basically, it's just an endothelial layer of simple squamous epithelium. So this is not going to provide any protection, but one of the things that we'll see, some epithelial layers actually produce secretions. So we might get back to that a little bit later. The tunica media, that's going to be circularly arranged layers of vascular smooth muscle. And this is important. So when this muscle constricts, we have vasoconstriction, which is going to make the lumen of the vessel smaller and also cause an increase in pressure. Whereas relaxation will result in vasodilation, this widens the lumen and we will see a decrease in pressure when this happens. The outermost layer is going to be the tunica externa, and this is just areolar connective tissue, and it helps to anchor vessels and other functions such as that. I do want to get back to the tunica media because there is something important that I want to address here. When we talk about vessels, the only receptors we are going to find on vascular smooth muscle, arteries, and veins are adrenergic. That's important. There is no cholinergic receptors on vascular smooth muscle. So the parasympathetic nervous system really has play no role when we talk about vasoaction. So it is going to be dependent upon the absence or presence of sympathetic activity and the receptors that are involved. Now here we're basically looking at a slide. This is a histological image of an artery versus a vein. And there are a few things that I want to point out here. When we're looking to identify a vein, the most important thing to look for is a large, irregularly shaped lumen. If we look at the artery, we're going to see a much smaller lumen. It's going to have a much more regular shape. And the other thing that quite often we'll see is a much more well-developed tunica media. So a lot more vascular smooth muscle here than we see in the vein. But once again, look at the lumen. If it's large and irregular, you're probably looking at a vein. That's an important thing to keep in mind here. When we talk about capillaries, they only have the innermost layer or that tunica intima. And that also should make sense because when we talk about what happens in capillaries, it's all about exchange. And if we were to have a thick endothelial layer, then that would inhibit and make exchange much more difficult. Now here, we're looking at a side-to-side comparison of vessels for the most part, and there are a couple of things that I want to point out. If we look at arteries, look at what happens to the lumen as they get further away from the heart. It decreases. So this here is indicating that as you get further away from the heart, there is going to be a decrease in pressure. But because of the change of the diameter of the lumen, this is not going to be as dramatic. So remember, we think about arteries as a pressure reservoir, and it is important that in arteries, they maintain their pressure as long as possible before they actually get to a capillary bed, because once again, it's the driving force. When we look at veins, we think of them as a volume reservoir. And look at what happens to the size of veins as they get closer to the heart. Now we're talking about a much greater lumen. So we see a decrease in resistance. And once again, on the venous side, pressure is our enemy. Veins really act as a volume reservoir, and that is exactly what they're designed to accomplish. The other thing that we want to keep in mind here when we're talking about both arteries and veins is the flow through these vessels. The flow through an artery is pulsatile in nature, whereas the flow through capillaries and veins is actually continuous. It is no longer pulsatile once we get to capillaries and veins. Now, if we look at the different types of arteries, as we said, they basically decrease in diameter of the lumen as they get further away from the heart. We're looking at a decrease in elastic fibers, and overall a general increase in the relative amount of smooth muscle. The three types of arteries are elastic arteries, muscular arteries, and arterioles. So here we want to take a look at elastic arteries. They're the largest, and if we look at diameter here, 2.5 centimeters, that's almost an inch. So they have a relatively large lumen, and the role here is to conduct blood directly from the heart to muscular arteries, which are the next category of arteries. Lot of elastic fibers, so this allows for not just stretch, but recoil, and this recoil helps propel blood through the arteries when the ventricles are relaxed or in diastole. Examples of arteries that we consider to be elastic are the aorta, the pulmonary trunk, but it's not limited to the great vessels of the heart. Other examples of elastic arteries would be the common carotid arteries and the common iliac arteries. The next group are muscular or distributing arteries. These are what we consider to be typically our named arteries. They are medium in size, and their role is to actually distribute blood to specific regions of the body. And these are going to allow for vasoconstriction. Okay, that's going to be an important thing to keep in mind. And when we look at examples of these types of vessels, think about the brachial artery, our coronary arteries, the femoral artery. Those are all examples of these muscular or distributing arteries. The last group or category of arteries are arterioles. They're the smallest of the arteries. They have 3 tunics for the most part. And when we look at smaller arteries, they're going to have an endothelium and a single layer of smooth muscle. These are going to be have smooth muscle that is usually somewhat constricted. And these are the vessels that actually regulate systemic blood pressure and blood flow. So arterioles will actually feed into capillary beds, and we'll see that in just a little bit. Now, the next couple of slides are going to address clinical issues that are specific to arteries. The first that we're going to look at is atherosclerosis. And I'm going to spend some time here because I think it is important to understand the overall process of what atherosclerosis actually is. And it's also important to keep in mind that this is a chronic progressive disease of elastic and muscular arteries. And basically what is being formed is an atheroma. And we can think of this as plaque. And this plaque is actually a thickening of the innermost layer, and it results in significant narrowing of the arterial lumen. So this is going to create significant increases in resistance. So the heart is going to have to work harder, or we're going to look at greater pressure that's necessary to move blood through these blockages. Now, under the current theory that we think is responsible for this process is a response to injury hypothesis. And this injury, and this will be to the inner wall of the vessel, okay, could occur by high blood pressure, there could be some infection, or trauma. Now, regardless, the result is the same. There is an inflammatory response, and this appears to be a chronic inflammatory response resulting in the formation of the plaque. And basically what happens, this process continues. The plaque becomes larger, and then we're going to be looking at a narrower lumen. And typically people are not aware of these plaques until they actually restrict blood flow to a particular region. If we're talking about a coronary artery, the first sign that they have this atherosclerosis could be a severe heart attack or myocardial infarct. Now here we can actually see a really clear difference between a nice clean artery versus an artery that actually is experiencing atherosclerosis. Look how much narrower the lumen is. So it is significantly narrower. To keep in mind, we actually look at a relatively large amount of plaque, and this is a really good example of an artery that's undergoing this process of atherosclerosis, and the plaque is just increasing. Now, I do want to spend time here because I think it is important to kind of understand the role of some dietary factors as they contribute to heart disease, but also the typical type of treatment if someone does have these blockages. So one of the things that I want to point out here is due to cholesterol in the blood levels are increasing. Now, I do not want us to think of cholesterol as always bad because it's not. Go back to AMP1, and we know that cholesterol forms an important part of the cell membrane, giving it that fluid mosaic characteristic that's associated with that. Also, if we look at all of our steroid hormones, those are all derived from cholesterol. So cholesterol is a very important substance. And generally the problem here is in individuals that have a genetic aberration and they have hypercholesterolemia. So they have much higher levels of cholesterol than we typically see overall. Males tend to be more affected by this than females. And if we look at other issues that are kind of playing a role with this atheroma formation, smoking and high blood pressure. When we look at both of those, they are actually creating situations that may damage that inner lining of the vessel overall. And what this image here is showing is the process of angioplasty. And so what they do is they typically will insert a catheter, generally through a femoral vessel. And here we can actually see the atheroma. Now, what they're going to have here is an uninflated balloon and a compressed stent, and they are passed through a catheter to the area where the blockage actually is. Then, once they've arrived at the plaque, the balloon inflates, this expands the stent and inserts the stent and keeps it in place. And basically, it kind of compresses the atheroma. But the result here is basically the stent is keeping that vessel open. And that's going to be important because now that vessel is open, that plaque has kind of been squished off to the side, and blood can actually move through this vessel due to the fact that the plaque has basically been narrowed and there's been a minimum decrease in resistance due to putting this stent in. Now, the other process is incredibly invasive, and that is a coronary bypass surgery. That typically is done when we have individuals that have 3 or more really severe blockages. Ideally, it's better to go with the angioplasty first because this is, once again, the least invasive of the treatments that exist for these blockages. The last few that we want to take a look at is going to be an aneurysm. And what's being shown here is a aneurysm found in the abdominal aorta. And this is a relatively large aneurysm if we compare it to a nice healthy aorta. And what's happened basically here is there's a ballooning out and thinning of the wall of the vessel. And what this means now, remember, the aorta is under especially high pressures and the wall is more likely to rupture. And this can result in massive bleeding and death. Okay, something that we see in elastic and muscular arteries. And one of the things that happens is just risk as we get older, where the vessels are less able to withstand the forces that are associated with pulsating blood. If we look at vessels that are most common are going to be the aorta or arteries at the base of the brain. If we're looking at the brain, now we're looking at a brain aneurysm, and these are especially serious because if we think about a vessel bursting in the brain, there's nowhere for this extra pressure to go because the brain is encased by the skull.